Hello, everyone. Welcome to week 6. Today we'll be talking about clinical documentation. So the purpose of this video, this lecture, is to understand how we write clinical documentation, why we write this way, and how we write it, okay? And also the reasons why it's important to use this type of documentation and this type of language when talking about patients. So let's go ahead and get started. So clinical documentation is the foundation of a patient's medical record, in this case, behavioral health record. It captures patient care from admission to discharge. So the notes that we're going to be focusing on in this class are called progress notes. So the purpose of the notes are to assess the progress of the patient through treatment, whether or not they're meeting their treatment goals, if their symptoms are getting worse or better. So these are the things that we're going to encompass in these notes. It's also going to include any diagnoses, so we will not be diagnosing in this class. You may or may not be diagnosing in practice. Likely you will have to have a master's degree unless we're talking about substance use disorders. In that case, just being a CDP or a CDPT is appropriate for diagnosing chemical dependency. Okay. So when documentation is complete, detailed, and accurate, it prevents ambiguity and improves communication between healthcare providers. So also with progress notes, we want to make sure that they're accessible and readable for other clinicians so that they can see what we did in treatment with them, what needs to happen moving forward, and so that we can really accurately describe how the patient is changing through treatment. So conversely, incomplete or inaccurate documentation can adversely affect the quality of patient's care, leading to med errors, longer lengths of stay, inappropriate discharge patient follow-up, higher admission rates, and increased care costs. So some of the reasons why we use clinical writing is first of all, we want to make sure that we are aligning with ethical and professional integrity. So we want to make sure that essentially we're staying in our lane with our care. We want to make sure that we are not utilizing strategies and interventions which we haven't been properly trained in. We also want to depict that we are treating and conversing with our patients in a way that's professional and ethical. Also, clinical writing, any kind of notes that we use in behavioral health care can be asked for by courts. So we always want to make sure that we're using our professional writing and we're writing in a way that accurately assesses and describes the patient, because there might come a time where we have to appear in court and report what we've learned about the patient throughout treatment. So we want to make sure that all of our bases are covered there. Also, clients may or may not see this information also. So not only is this information going to future providers or current providers, so those providers are going to read our notes so they can accurately understand the patient's experience in treatment. And then again, like I said, the client may see these notes. So we want to make sure that our note-taking abilities are doing the least amount of harm. Okay, so we want to accurately describe patient symptoms and experiences, but we want to do it in a way, if possible, that wouldn't be offensive to the patient. I know that there is some legal things that have to do with behavioral health care progress notes. So I know that at Peace Health, the provider has to approve whether or not the patient sees behavioral health care notes. So for example, we had a patient in the program who had some pretty extreme symptoms, difficulty communicating, lots of behavioral issues, lots of concerning experiences with staff and other patients at the program. And so very much so, we were constantly writing about uh, the things that the patient was doing in treatment that was inappropriate, because like I said, that can be telling when we go to diagnose somebody or how we continue on with treatment. And so she was requesting the records. Much of the staff at the program did not want this patient to have the records for fear that there would be some type of um, violence or harm to staff if she was able to read those. So depending on your organization, like I said, the patient can always request their documentation, but we are not always legally obligated to provide it. However, I would always approve it as long as I have been able to accurately pin down whether or not it's going to be harmful to the patient. And then I'm also mindful of this in the notes that I take. I want to make sure that I'm as accurate as possible and that I am, what's the word? As appropriate as possible, okay? So part of what we'll do when we're writing clinical notes is that we will, again, write down what is actually said by the client and the people connected to the client. So this may be family members, clinicians, friends, or colleagues involved with the case. It also includes what the client thinks or feels, or what their impressions are about their situation or about treatment. Objective facts also communicate pertinent information about a client to colleagues for case review. So it is a Washington administrative rule that there are multidisciplinary team meetings, or as many disciplines are within your treatment center, that they meet and everybody reviews the case together at least once a week. So we want to make sure that we are accurately describing and using as many quotes as possible when we bring these intake assessments or progress notes into the team meeting so that we can really get a good grasp on what the patient needs. We also communicate pertinent information about a client to colleagues for case planning, like I said before. Objective facts establish in writing an account of what the client is currently experiencing at a particular moment in time. So for example, the biopsychosocial assessment offers baseline information, and then our mental status exams are going to want to see how that baseline has changed over time. So what has the progress been? It also offers the counselor or case manager an opportunity to reflect on, refine thinking, and raise questions about a client and their situation, and to digest information about and impressions about the client through the process of writing about it. So subjective impressions, so this is where our professional opinion comes back in. So these include the counselor or case manager's insights, beliefs, hunches, guesses, inferences, speculations about the client and his or her situation or their presenting problem based on the objective material presented by the client. So we want to formulate a professional assessment or a professional opinion about what's going on with the patient based on what they presented. So we want to be sure that we are providing evidence for our opinions as well. So for instance, so these are statements that the counselor or case manager makes about what they believe are underlying or meaning or motivations for the client's remarks, actions, patterns of behavior, experiences, interactions, and feelings. So again, back to an example. Patient appears anxious because they were shaking their knee or tapping their thighs or using long pauses or lots of ums. So there might be anything that would describe why they're anxious or nervous would go in that evidenced by piece. So using tentative language, so again, this is for an example, patient appears to be a tentative language example. So tentative phrases tell the reader that the writer is going to make a claim that is based on inference or professional opinion, interpretation, suggestion, hypothesis, or ways to move beyond what the client has said to what the counselor case manager reads from the case material to shed light on the client's underlying meaning and motivation. So for example, some examples of how tentative phrases begin: it appears, it seems that, this points to, this suggests, or it's unlikely that. So just some other examples here. So an inference is the act or process of deriving logical conclusions from premises known or assumed to be true. So again, professional opinion based on our experiences. Interpretation, which is a representation of the meaning or significance of something. The act or process of explaining the meaning of something. So what do we feel the meaning is of how the patient was responding or what the patient's behaviors were? Suggestion, the sequential process by which one thought or mental image leads to another by association. And then hypothesis, so a tentative insight or explanation for an observation or phenomenon that can be tested by further investigation. So you will notice that there may or may not be a sentence or two that starts with "it appears" or "it seems" in your MSc case studies or your MSc info of the case studies. And so if there is not, which this is going to be required in your DAP note and your MSc, that we do make professional opinions about what we see regarding the patient's behavior and report. Coverage and balance. So we want to make sure that the report contains enough useful information and that it has a balance of information, including the client's strengths and difficulties, objective facts and subjective impressions, and material from multiple data sources if it's available. We also want to make sure that the information is prioritized or presented in a way that highlights key clinical issues for the client. Okay, and we're going to move through here and we're going to see a couple examples in the MSc and DAP note lectures. So hold tight for that and then I'll show you some examples. We also want to make sure that we're using non-judgmental language. And so there is a video this week on person-centered language. So this is simply, we're not going to say he's a schizophrenic. We're going to say this is a person with schizophrenia. We're not going to say she's a borderline or she's a bipolar. We're going to say she is a person with bipolar disorder or a person with borderline personality disorder. So another good example of this that people might be familiar with is describing yourself as an addict or an alcoholic in a meeting. While I know that that is tradition, I've always kind of held on to that, especially when I was utilizing the program for support. People are so much more than addicts or alcoholics or their mental health diagnosis. And so we want to make sure that we are accurately describing that in our documentation. Also, I know I didn't do a great job in the case study on making sure that I was using singular pronouns. So this is something that I do frequently at my job. We had a lot of instances at work where people are mispronounced, and so we are moving towards writing all of our documentation in a way that is not gender specific, where we're using he or she. So we are using they and them and theirs or their pretty frequently, as well as the patient said or the client stated or service user stated. So again, I do apologize that that was not accurately depicted in Caden's case study. But that is something that I want people to be cognizant of. And it can be kind of difficult learning how to use these singular pronouns, but the more that you practice, the easier it becomes. There's also an optional resource this week under mypronouns.org. So take a look at that if you would like to learn more about using they, them pronouns in clinical documentation. And that is it for now. So please feel free to move through the rest of this module and then on to the DAP note section.